think about COVID-19 frontliners, who comes to mind? Emergency department staff, pulmonologists and critical care physicians and nurses? I'll bet most wouldn't imagine physiatrists to be in the front line, caring for people actively ill with symptomatic contagious COVID-19. I never imagined that work for myself either. I'm Kimberly Heckert, and as a physiatrist in an academic medical center, I had a career I was quite content with in early 2020. I had a busy clinic where I enjoyed teaching PM&R residents and directing our spasticity fellowship program. I also enjoyed serving as the director for the physiatry consult service at a large privately owned subacute facility in Center City, Philadelphia. I still enjoy all those areas of my practice, but on March 19th, as for many of you, my job changed quite drastically. We admitted our patient zero to the subacute, a young man in his 20s who had symptoms of COVID-19 upon arrival. We knew little about SARS-CoV-2 then, and in early March, the landscape in care for people with COVID-19 was quite different. At that time, it was difficult to get testing, and results took sometimes weeks to process and receive. Our attempts to isolate this young man from other patients failed miserably to stop what would become a terrible tragedy, a mass outbreak in the subacute that would leave a number of my patients dead. Shortly after the outbreak, members of the Philadelphia Health Department came in hazmat suits. A decision was made to evacuate any remaining healthy patients. From there, the facility had two choices: shut down entirely or become Philadelphia's first all-COVID rehab facility. Leadership chose the latter. Suddenly, the building, which typically ran at a census of 120, was at 100% capacity, with 147 of the sickest people we had ever accepted. The facility had basically become a large COVID step-down unit for the city of Philadelphia. Changes occurred almost overnight, with up to a dozen admissions a day pouring in from local and remote hospitals during our initial surge. We quickly adapted to new procedures. I covered my hair and donned an N95 before stepping into the building, then put on a double-layer microfiber gown and shield. I wore my PPE the entire day, not removing my mask to eat or drink. Spaces were repurposed as tables and chairs in conference rooms were replaced with spare oxygen compressors, CPAP machines, and other respiratory equipment. Therapy gyms became decontamination areas for staff and equipment. One of the things I remember about those early days was just how awful all the patients looked, frequently draped over a bed or chair, meal trays sitting untouched because none of them ate. I couldn't believe how quickly people decompensated with minimal exertion. The disease was new, and I was reading everything I could at night, listening to online resources, exchanging information with colleagues, trying to educate myself on how to care for these very ill patients. The level of acuity and frequency of setbacks made many days difficult. The gravity of the emotional toll of this illness on patients was also apparent. Tears were common, especially when taking a history, asking the usual questions that physiatrists ask. Do you live with anyone? Then a pause and somber reply. Well, I did, but my wife didn't make it. Or I live with my son, but he's still on a ventilator at the hospital. Isolation, as we learned, is terribly hard. I met with the director of therapy early on, and we quickly devised a plan to provide therapy for this full house of sick COVID-19 patients. The plan included performing a functional screening evaluation on every patient and triaging them into groups of lower, intermediate, and higher exercise tolerance and functional levels. We then devised leveled exercise programs that could be done with therapists in the patient's room so they could remain in isolation. Equipment circulated on large wheeled carts and was brought to each patient. We continued as a COVID facility for the next 10 months. Because we were one of the first COVID facilities in the region, other subacute facilities borrowed our protocols. At one point in the summer of 2020, I received a call from a business administrator for my department who remarked that, based on visits I coded for COVID-19, I had seen an unusually high number of COVID-19 patients. more than many of my intensivist and emergency medicine colleagues in the enterprise. I think many would have been surprised that one physiatrist, a small fish in a mammoth academic healthcare center, could have this degree of impact. That a doctor amongst those seeing the most COVID-19 patients was me. As physiatrists, we don't always think of ourselves as the essential front line. Historically, we've been considered, regrettably, the last line when all other means of medical and surgical treatment have failed. And though the understanding of the role of physiatry has changed for the better with time and education, I imagine many of you were also surprised to find yourselves at the front line. This work is very different than the work we have known. Or wait, is it? I will argue that the two most important things to a physiatrist are goals and barriers. What are the goals for the patient, and what are the barriers to achieving them? At the heart of what we do is the identification and overcoming of barriers. It's in our training and it's in our blood. When our patients can't negotiate stairs, we strengthen their hip extensors, teach them to bump up the stairs, or accommodate by installing a ramp. We find a way, and when the way doesn't exist, we make the way. We physiatrists have been innovating since our very inception. We look at the barriers to progress and set a course to overcome them, and 2020 was no exception. At my facility, we applied the basic principles of rehabilitation medicine to mobilize people suffering from COVID-19. And in doing so, we served a great need in Philadelphia, a city hit hard, especially in the first wave. By sharing what we learned, we helped other centers. And while we initially signed a lot of death certificates, we ultimately brought a lot of people home, including this lady who decided to walk home on her day of discharge. So why tell you my story? You lived this. You're likely as sick of hearing about coronavirus as I am. Well, hopefully we will never see another pandemic in our lifetime, but there will be other catastrophes, some bigger, some smaller, and we must lead the way forward because we are well suited to do so. This is especially true in the subacute setting, where many physiatrists serving in consultative roles tend to step aside because we aren't employed by those facilities. But we must not be shy about our leading. As physiatrists, we are natural leaders. We are innovators. All of us here today have been encouraged by the AAPM&R to be bold. And so I urge you, become good at articulating what you do, because it's meaningful and it's impactful. I can't think of a job more fulfilling than one in which you get to journey with people in their most vulnerable moments and problem solve with them to help them regain independence and dignity. Rehabilitation restores lives. When we don't lead, we get cut out. When we don't lead, we are left to react, and those who stand to lose the most besides ourselves are our patients. Lead and problem solve, especially in times of crisis. Winston Churchill said, "Never let a good crisis go to waste." Out of crisis, we can show how essential we really are and have always been. You too may find your leadership has a much broader impact than you may have envisioned. And leadership doesn't mean you'll have all the answers. Believe me, there were moments I felt I had nothing to offer the people in front of me. And in those very dissatisfying moments, I decided to offer hope, because I have come to believe that hope is the most powerful medicine of all. Onward from crisis, may we carry these lessons forward. Be on the front lines of positive change. Look for the signs of hope and be the signs of hope for others. Lead the change you wish to see from wherever you are. Thank you.